Okay, fantastic. Good afternoon, and of course, thank you for giving this opportunity for our live relay. This will be the second year. Actually, last year was 1 year, 1 day later. It was April 13th, and today is April 12th. And how is
Well,
the
we're
meeting
glad to
going
have
on?
the two of you. We're glad to have the two of you. Let me introduce our panel. We got James Aaron Grantham, John Casala. We got Bridgemani and Michael Young. And I'll try and be yours and PK's Dr. Phil today, okay?
Oh, great. And we will, of course, with the extreme, our panelists will need a lot of help in this particular case. So clearly myself and Dr. Keeney on the left side. Can we see our other staff? Assad is my associate attending and the fellows and rest of the cath lab staff. Really thanks everyone. And we start with this case. We were asked to present a case of left main LV dysfunction, calcific left main. And exactly this is what the case is. We'll show the slide presentation, and this is our 76-year-old male. Patient has a long-standing history of CAD, has stents in the right coronary. Recently was admitted with non-STEMI and LV dysfunction at outside hospital, and cath revealed additional disease in the left main, LAD, and ramus. Because of and patient, of course, these kind of cases go hard team discussion. Patient has COPD, lobectomy, CVA, and decision was made that too high risk for surgery, and that's how this patient was referred to us. But patient, they also did the stress system AB, and that showed apical infarct, but ischemia in the anteroseptal and anterolateral area. So clearly it's a viable myocardium and a viable ischemic myocardium. And with that note, the patient was referred here for high risk protected PCI. Yeah, I know you should take it through.
Yeah, so if you see here, this is how,
Yes.
yeah, calcific right femoral, as well as this is our picture. Can you show the angiogram? Yes.
Yeah, louder.
Yeah. Can you hear?
Yeah.
Can you hear me?
Yes. Now you can.
Yeah. Okay, so here you have the right femoral artery, heavily calcified, calcific iliacs. So, but still we were able to get true pre-closes, and what we did was actually after introducing the impella, we took the sheath out. So right now just the impella catheter is in the
Janine, I'm sorry
body.
to do this to you. I didn't mean to interrupt you. We still cannot hear you, Kenny.
Okay, so while they're adjusting Keeney's microphone, so basically the right coronary, as you can see here, there are stents there,
Move this.
which have been patent, and this is LV. EF was 25%. There is a mild AS, about
Come here,
15 millimeter
scientist.
gradient. You see the
Hello.
apex in this LV dysfunction, you have to rule out the LV apical thrombus, and showed no thrombus because echo
You
was
can
done
hear?
just here, and we put impella. So if I wanted to take you through, if we can show this picture, can we say the overhead? That remember the sheath of the impella 2.5 is 13 French, and the CP is 14 French. So in patients with the borderline iliofemorals, what we should do is, after inserting the impella, take the sheath out and break it. So can we show the left groin, please, from the top camera? Yeah, good. They are seeing it, yes. So see that, and this is about 11.5 French sheath, so cause less ischemia. So many times you leave the 13.5, 13 plus French sheath in the disease iliofemoral will cause ischemia, and so it requires a little breaking, but then you advance the blue advancer, and maybe sometimes you have to hold a little bit, or if you have perclose, one perclose, maybe put a little tight so that it does not bleed or ooze around. So with that note, let's go to where the the meat is. Is this distal left main, and this is the picture actually. The trifurcating, the ostial LAD level, then the ramus, and the continuation of the LADs. The real circ is just very small. So it is clearly before the dye comes in, as we go with the usual criteria of the severe calcification, there is a tram track. So I would call it severe calcium. And we felt that maybe just to demonstrate that how does this circular ring will look unwanted, do the IVUS. So show the IVUS. Can you?
Nope.
We're sorry, Dr. Keeney, we still can't hear you.
Okay. Yeah, I know. So they have to get a new microphone. So now see this here. So it is such a severe calcium, the IVUS does not go. This is our run-through wire, workhorse wire.
Let's check.
And IVUS will not go into the, just at the distal part of, whether we call it ostial LED or just the trifurcation, because very small circ, so would not cross. Second, we say, okay, what about the ramus? Look at the ramus also.
Can you
it
hear
will not
the-
cross now.
Can you hear me now?
Yes.
Huh?
Right?
Yeah, but I can't hear them.
Any pictures, it's still helpful.
Yeah. Yes, they will show it what exactly it is, yeah. Okay. Now what about, can you hear, Dr. Keeney there now or no?
Say
We
something.
can hear you, we can't hear her at all. I think we
They
got
say
a
they can't hear
battery
me.
out or a microphone
We
not working or
have
something.
changed
Okay,
every microphone.
let's see one more second. What about my fellow Assad?
This is hers.
That's the changed microphone.
Can you hear me? Yeah. No.
Their battery situated. John, what are you seeing so far?
Yeah,
See a tremendous amount of microannular calcium.
Oh, it's a
yeah,
system.
yeah, that's a severe mitral annular calcification. There is a little bit of aortic calcification
Huh?
also. Yeah,
We got you.
okay,
Huh? Can you hear me?
There you go.
good. Now you're on, good. Okay, now show that
Okay,
what
now
is
we
shown
can.
the
I'm
IVUS.
showing the IVUS. This is the IVUS just at the level of the left main. Go the next. This is the left main. Go the next one. Oh, this is the left main. The first one. This is where our IVUS was getting stuck. Would not. This is a tight lesion, so you can see about more than 3/4 of calcium across ostial LED. So we could not do the IVUS of the LED itself. Though the lumen is large because of the calcium, I think that's the reason the IVUS catheter would not get into the LED. So in this situation, you know that is significant calcium, so consideration of atherectomy is essential.
So that is what, John, you were saying, that even if you did not cross, it gave you that information of the complete, not complete, near complete ring of calcium, that this is the case, should be done with the atherectomy. So while, go to the slide sets again, our slide presentation, so that we complete that. Yeah.
Dr. Keeney, it's Amin. One quick question too. You mentioned
Yes.
the apex was out. Did we get an echo to show that there's no ventricular thrombus?
Yeah,
Yeah,
we
yeah.
just had echo
Right.
before the patient
Absolutely.
came in, which showed a EF about 30%, antroapical hypo, but no evidence of thrombus.
Yeah.
He does have some calcific, aortic stenosis, the gradient about, 2 meters per second.
Wait one
Yeah.
second. Good, let me just complete the presentation now. So based on, go to slide before, please. So basically our guidelines are these complex cases, you calculate the syntax and the STS and heart team discussion. As you said, this patient has been already discussed with a high STS score of 5.6, anything more than 5 is bad. And here for the left main and 1 to 2 vessel intervention, because picture was not clear whether there was disease in the ramus, though I would call it now left main and 2 vessel. Next. And in our new appropriate criteria, next, it will be appropriate because CTS decline. Now, as you know, despite the calcium, next slide, the overall, the atherectomy volume is just about 5%. We don't have clear-cut difference, from ACC and CDR, how much is the ROTA or OA, but market share point of view, it looks like about 60 and 40. Next. And we also did the trial because using all these devices for these calcific lesions, particularly the rotational and orbital atherectomy. Next. That in the two of them, so, and we'll come back to point maybe discussion few minutes later, that where you use rotablation versus diamond back orbital atherectomy. Next, slight different principle of acting for both of them. And more important, the MACE trial, some of you have been author in this paper, that in United States, until 3 years ago, this is the trial where 100+ cases in each group, and severe calcium only 1/3 are being done with the atherectomy. It was only rotational atherectomy allowed in the trial because Orbital was just getting approved. Next. And the key also is there is the severe calcium, which is the trouble. And those are the one have high problem, not the mild or moderate calcium. Shown the data at 1 year in terms of the TVR and MI, only in the red bar, which is the severe calcium. Next. And the second point is Impella support. Next. Of the 3 devices, Impella is very easy. That's what we have inserted. And use basically, unless hemodynamic issue, we go with the LP 2.5 and CP more for hemodynamic cases, and that's where cardiogenic shock initiative has come up. Next, and the last, this slide, next, this is the complexity. Next, the combining LV dysfunction, the Impella, particularly the group of that 20 to 35%, where Impella has very important to get a good result, and that's where we are in this particular case. Although now, if you make a next slide, that even there is a push for now, even patients with complex CAD, but near normal LV function, with the recent approval of the device, can be used. Yeah.
I'm going to, in the interest of time,
Good.
great
Fine.
didactic.
Yeah.
So
Good.
tell us what the
Yeah.
therapeutic
Good.
strategy is
Okay.
going to be.
Right here. Go back to the floor now. So we are done. Cross the lesion.
We use a fielder wire. This is the fine cross. We are across the lesion,
Yep.
and we change it to the rota floppy wire now.
So question was that should we use a 1.5 or 1.75 bar, knowing that the IVUS did not cross.
That's an interesting question. Do you
Yeah.
start with the burr that you think is going to give you the optimal result, or do you usually build up?
We
to
have 175, no?
175, etc.?
Yeah, no, but very good point. So,
We never got to see the IVUS.
yeah, could not. Remember, IVUS never crossed the lesion.
Seen the IVUS.
IVUS never crossed the lesion. We did showed at the level of the left main and ostial LAD. Can you show it back to them, IVUS?
It did not cross. Yeah.
Which was not severely stenosed, even though you couldn't cross. You know, a 175 might be a better choice, give you more cutting. If it's very high-grade stenosis, you're certainly not going to start with a 175 usually, but 1.5 is your most.
That's a very good point, John. Yeah. In this particular case,
IVUS goes through, use a 175. If it doesn't,
Yeah.
use a 1.5.
exactly, that is what we did.
Your burns are without an IVUS, so you got to.
Yeah. So that,
As they're working, as they're working, when you are confronted with these types of cases, I'm assuming that this is a heparin case for you. There's no role in your mind for bivalve or
One more
something
1,000.
else like that, correct?
Yeah,
One
we
more
switched
1,000 heparin.
back From bivalve to almost exclusively heparin.
And believing that this is going to be a PCI, these patients are loaded with dual antiplatelet therapy before they're put on the
prior,
table?
absolutely, almost everyone.
You know, I'd like to have Dr. Grantham weigh in because we had a discussion before this case about his ongoing study because, you know, here's a surgical turn down, but the STS score is only 5 and change. A lot of things are not weighed and or captured in the STS score. One of them is, of course, pulmonary hypertension.
Yes.
Another is hepatic disease. And the fact is your surgeon is going to be very discouraged about somebody who's got a visible stroke on their neurologic scan and is an atrial fibrillation, which is going to increase the risk. So, Aaron, can we readjust some of these things a little bit better?
We certainly hope so. So we're coordinating a 20-center registry called Optimum, and there's going to be 700 patients who are declined by surgeons for surgery. They have surgical anatomy, ineligible for surgery. It's kind of the partner cohort B equivalent for coronary artery disease, trying to put the genie back in the bottle for PCI and demonstrate efficacy of PCI in patients who don't have a surgical option. So I hope that we'll be able to come up with a new risk predictor score for PCI in this setting. Very little is known. There's a VA Awesome trial where they randomized patients who were high risk for surgery between PCI and medical therapy and PCI and surgery, and there were equivalent outcomes
one second.
back in the low IMA days and the POBA days. So there's really nothing to go by. And this will set up a randomized trial, I think. It'll help inform us of a randomized trial. But it'll also give operators around the country doing these high-risk procedures who don't get credit in a risk-adjusted analysis for the real risk of the procedure. There's so many other risk factors that aren't accounted for in any of the PCI risk prediction tools.
So Bridge, you've been doing intervention for a long time. If the year is 1999, we see this coronary anatomy, we shrug our shoulders and say, call a surgeon. I think this is indicative of how we've come full circle, where these patients are now being turned down for surgery for a number of reasons, and because of support, because of mechanical circulatory support, because the tools are better, now they're coming back to the cath lab after a heart team approach.
And that is absolutely correct. Yeah.
I would actually suggest most of them see a surgeon and then don't see anybody else for a long time, and sometimes they stumble back to the cath. Not enough of them are referred back for an alternative therapy. So somehow surgeons have become the final arbiter of revascularization, and when they can't do it, nobody can. We can do a lot of stuff.
And that's the full circle of coronary intervention in the modern era. John?
Yeah, I think in our institution, because it's somewhat in a exclusive environment where you only have you're the only LVAD and transplant service in a couple hundred miles, all of these cases, for the most part, are coming in through the transplant surgeon.
Okay,
They're the ones who are saying, listen, they're not quite ready for an LVAD. If you can do something in revascularization, that might be a better alternative, at least straight up.
So what do you do? What are you seeing on your in terms of D cells or anything like that?
Yeah, nothing actually less than 3,000, and this is a 1.5. As you suggested that since IVUS did not cross, we downgraded from 1.75 to 1.5. So the question always comes, what to do now? Do you upgrade? You already have a 1.75 bar on the table, or you just try to open the lesion with a side-by-side wire and see if it expands. Then you don't put a 1.75. Otherwise, do ablate with a 1.75 bar. Let's take
Michael,
a picture.
What are you going to
Yeah.
do now?
Yeah.
Michael, what are you going to do now?
I'll play it.
Okay, Arth?
I'm going to do just what I was taught to do by SS and AK. I'll try a compliant balloon, see if it expands. If it expands, then I'll move forward with stenting.
Get the Ryan
All right, what's the next step then, Shameen?
It looked like the 1.5 went pretty
So-
easily. I
Yeah.
doubt
Yeah.
there was much in the way of calcium fracking. I'd just go with the 1.75 and
Yeah,
then.
so this is always the disappointing part, when you think you've sized just right and suddenly you go through like a nice and butter.
Yeah. I know.
And you're wishing, you know what, hey, maybe, I don't know whether IVUS didn't cross, but that 1.75 sounded good.
But
Yeah.
it's modification now, right? I
It is slightly.
It's modification rather than your
The bulk.
angiographic result
Well,
may
the
not be.
But we
the
might want to
same
modify it a
result.
little more.
And the best way to do that is with imaging. Ivan will show you calcium fracking or not. And if it's still
Your
just
balloon.
circumferential, 270
Yeah.
degrees of calcium without fissures, then you need to do a bigger burr.
So tell us okay, so you're replacing your wire. Tell us, kind of take us through your steps.
So right now, I did side-by-side wiring with the
Yeah.
run-through wire, and then we have a 3020 balloon, high pressure.
So
That
we're
will
not
tell us-
using an end-hole catheter now, we're using side-by-side.
Side by side. Yes.
Yes, this will be a side-by-side wiring.
Now, question was.
Didn't you just recently
Yeah.
present some data that talked about gouging and larger MLAs with OA versus RA. Could you talk about that for just a second?
Yeah, I think what we have learned is that even at 80,000 RPM speed with the OA, it really caused the deep cuts. And is that be responsible in some cases, particularly if you go to a little higher speed? So this is at 12 atmosphere, 3020.
It's really
that-
important to look at that in two views
Yeah,
because you can
yeah.
still get some fairly eccentric
Yeah.
lesions and not have complete expansion in one view.
So what balloon is that, I'm sorry?
It's a 3020 non-compliant.
How far you went?
Non-compliant. Very important
16.
that this is a
16.
non-compliant balloon.
Yeah.
And it's right size to the vessel, that it's not undersized, because you will
Yeah,
not
exactly.
see incomplete expansion of the balloon,
Mm.
undersized
Good.
balloon.
Your point, Aaron, is that it looks fully expanded here, but if you rotate to another view, you might see an hourglass shape to the.
Okay,
I always
so
check
we'll
them
give
in
you the
terms of-
different view.
There
So
still
good.
looks like a little waste
Good.
on that.
Okay.
Yeah, we went through our rotoblader course the other day. We pointed out the importance that even though you've rotobladed, it doesn't mean that you're going to get great expansion.
Good. Let's go.
So you
We're going
have to
up.
use non-compliant balloons,
Yeah.
either heavily
Yeah.
calcified
Now we have to
regions.
wire the side
They have
branch.
a lot
no?
of spicules
do
that
it
may
now.
still be in there that can lead to rupture, but you want to make sure you get a one-to-one sizing, full
Okay.
expansion.
What do you think now?
Pressure
Great
take.
point. Yeah, look at that, just what you guys were talking about.
I think it's
No, this
just
this
taking the
calcium
shape of the
is
vessel.
That looks-
adventitial calcium now. Yeah.
Yeah, it looks fully expanded in this view,
Yeah.
and you can see a lot of the
Full
calcium
expansion.
on top of the vessel. The other view, though, I wasn't 100% convinced it was fully expanded. A little waste on it, I thought.
So, Samin, teach us, how often are you checking your ACTs, and what are we maintaining our ACT at? Are you a minimalist? Are you shooting for 250 to 275, or is 300 plus what you're looking for? How often are you rechecking these things?
Yeah, very good point. So in our system here, the whole cath lab staff is tuned to check ACT on heparin every 20 minutes and keeping it since 20 minutes, yeah, 20. And then key is that since you don't use 2B3A or use in very small number of cases, percent of cases, so keeping it around 300 is the preferred.
So 300 is your sweet spot.
Is still 300, yes. But I can tell, at our center, we are about 40% heparin and 60% bivalvulotin.
But not for a case like this, or you would use it for a case like this?
No, this case, I would use it for this case also. So only, I think, perhaps you're doing a radial, you're doing a CTO, it may make a sense that not using it, but otherwise we'll use a bivalvulotin. And this particular case is a little different. Yeah.
What balloon do you want?
The key point is that bivalvulotin is cleaved in stagnant blood, and during complex procedures like this one or CTO, when you have guides that have blood in them that sits there for 10, 15, 20 minutes, the bivalve's disappearing from that blood. And if you're going to use bivalve, you either have to flush new, back bleed to get new bivalve into the guide catheter, or you're going to have a guide thrombosis. We did a little study of 25 CTOs on bivalvulotin. We had 4 guide thromboses and 1 sheath thrombosis. Not that those things never happen, but never with that frequency on heparin.
So where did we first find that out, right? It was in brachytherapy. We had a long dwell time with a catheter, which was closely sized to the guide, thrombus all the time.
If you're forced to because of hit, just flush the guide out repeatedly every 3 or 4 minutes. So back bleed it, get fresh
I knew that it's in the
bivalve in
wrong
there.
branch.
Another fielder. Another
So,
fielder.
Annapurna, what's our next step in this, and our strategy in this very complex strategy, very complex
So
case?
we are wiring
I know
the
you're only
side branch
thinking
with the
2 steps
fielder wire.
ahead.
Yes.
Yeah, since we were in the caudal view, we went into a small branch. Now the tip of the fielder wire has been distorted. We are taking a new fielder wire to go into the side branch, which we are calling the ramus.
2.5.
So for that one, we will
compliant.
use a cutting balloon rather than do atherectomy. And I think Arthur brought up a new point where I think we can show the slide why and which cases we should do rotational atherectomy versus which cases you should do orbital atherectomy. Maybe that we
On the
can
side,
bring it,
on the-
yes.
yeah.
Discuss.
But key is that now we need to take care of the ramus also. Because that's a very
Jeff
significant
sort of
lesion.
suggested that the challenge of calcium is nearly solved, but the one that we don't have a solution for is a horribly eccentric nodule of calcium,
Right.
where all of the devices are still prone to wire bias and an inability to get that. And does anybody think Orbital might be a little better than Rotational in terms of that nodular calcium that's on one side of the vessel?
Throw it out to the group. Bridge, any particular thoughts on this, or not sure?
You know, I'm really not sure whether one is better than the other, to be truly honest.
John?
I think I look at the wire bias. I mean, if the wire bias is in
enough.
favor of the eccentric piece of calcium, then the rotoblader would be fine. If it's not, it's going to reflect off the other way.
You know, I do want to compliment you, too. Every time I see you guys do a case, you are ultra meticulous about your wire. And if you look at that distal wire, it is wrapped around the apex, but you got a good safety J on it.
That's
and you've maintained a stable position for that wire. I really compliment you on what you're doing with your wire technique.
Very important because all these complex
Why we didn't
cases,
cutting
compliant
balloon?
right now, 2.5. Yeah. So this is the 2.5 compliant balloon, so we need a little further in.
Okay?
And then we get a 2.75 cutting balloon.
Yes.
Get up. Wolverine.
So you
Yeah.
prepped it for the cutting balloon.
Yeah.
And for you Michigan
Just the
fans out
ostium.
there, the new cutting
Yes.
balloon name is called Wolverine.
Down.
But
What a
calcium
name.
nodules are part and
Cop-
parcel of, I mean, they're present in kikvas, calcium is present almost ubiquitously, it turns out, whether it's soft plaque or hard plaque with erosion without a cap rupture. So, I mean, calcium is just always there in coronary atheroma, yes or no?
Well,
It is, but it's not always dense
Yeah.
calcium, and it's
Yeah,
not
not
always
dense. Yeah,
superficial calcium. The kind
but
of
but
calcium you get
but let me just put put into the
I just think
question.
imaging is so important in determining which device to use. The other thing that's a problem with Shockwave is in Shockwave, you really need circumferential calcium to get the
Yes.
reverberations that you need to get the calcium fracking. So it's not going to solve the eccentric calcification either.
So Aaron, where are we with
Actually, the
Shockwave
same,
right now?
yeah.
The
We're getting
availability?
ready to enroll
Trial.
in coronary trial.
Yeah, just the trial's about to get going.
Yeah. So now let me
For
just
those,
add to that point.
For those who haven't done, for those who haven't done Shockwave, you want to just explain it real quickly, Aaron? 30 seconds on Shockwave?
It's a balloon that emits ultrasonic energy at 35,000 joules.
Mechanistic.
It's
lithotripsy.
lithotripsy for the
It's-
coronary.
it's lithotripsy for the coronary. So you inflate the balloon, you push a button, it goes for 10 seconds, and then shuts off automatically. And you do that as many times as you feel like you need to do to frack the calcium in the vessel. But
What
it is-
happens to the media, though?
I have no idea.
Yeah. So basically what
I'm
it
not
did
I'm
is,
not a Shockwave expert. If Ziad Ali was here, who was involved in the development, he could tell you
urinated
all
out.
about Shockwave.
I'm just asking.
Yeah, there,
Yeah.
All right, so where are we at,
yeah.
Samin?
Okay,
So
so
we
just
did-
to, we did a
Problem with it is it's a big
2.5.
bulky device, it's not
Yeah.
going to go where you need it in circumferential
Yeah.
calcium.
So 2.5 followed by 2.75 Wolverine. 2.5 non-compliant and then 2.75 Wolverine. Now we have prepared the lesion to our double vessel mini crush technique stenting. Good.
So take us through your technique there. You're going to do a mini
stent.
crush?
Yes, so right now we will go with the one stent. We will need two stents in the LED. We'll take 3038 Synergy into the LED, and then we will do the mini crush between the LED left main to Ramus.
So it seems to me that, for the last couple of years, we've gone DK crush crazy, but I think there's nothing magic about the DK crush. I think it's the meticulousness and compulsivity with which you prep the lesion as they did, and then do your adjunctive kisses. Would you agree with that, John?
27520
yeah, absolutely. I
on
mean,
the
this is the
side.
key point for it, and this is all.
27520.
Jeff Moses talked about the chip operator and concept and things, and part of that is the details that you've mentioned in terms of lesion preparation, sizing, all before you get to the key component of actually deploying your stents, and then making sure that everything's optimally deployed afterwards. Some of the projections that industry looks at in terms of where the growth's going to be in the angioplasty industry, it's relatively flat to down compared in simple angioplasty. The growth market is in complex PCI, or maybe it's the way we grade it, but that's because the aging population, as you age, there's more calcium, there's more diffuse disease, there's more vessels involved, and as a result of that, you've got a complex PCI by definition. So this is the growth part of PCI. And this is where people are going to have to spend more attention.
Michael, what's your technique of choice for these sort of complex distal bifurcation left main lesions?
I do mainly
Good, no?
PK crush.
Okay.
Okay, go.
Yeah, the big advantage is you're only crossing one layer. The challenge is your final two-step kiss, you've got to get a balloon across 2 layers of stent, and sometimes that's a massive challenge, especially with an MC balloon. You wind up having to use a 1.5, prop it open, and then get a big MC balloon in there.
So by way of that, I'm going to turn this back over to Aaron as well. The study is going to have some financial implications too, right? It's going to show us how much we use, how much more it takes to do these kind of cases, much like orbital atherectomy was able to submit to CMS for higher billing
Okay,
codes.
so now give us
Is that the same
3540.
anticipated goal for your
Yep,
study?
we're going to do the same cost
3520,
analysis.
and
we'll
what did you
also
have
do
for
a
the other ones?
contribution
27520.
margin analysis
20.
and all kinds of economic analyses. And then compare those to
2.7520 also.
standards.
27520 first.
All right, guys, tell us where
Okay.
you're at.
Yeah,
What's the
good.
next
So we
step?
place the 3038 Synergy in the prox to mid LED. Right now we will go with the 27520 Synergy to the Ramus. And you can see the slides. We have our Bifurcate app. Anybody can download it free, and she's showing it in the side that we are doing the unprotected left main, and the patient is stable. We Medina classification 111, and we went to mini crush. So the side by side, you can see the slides playing. So I'm going to always go to the side branch first. So I'm going to the side branch. You'll see advance the wire a little bit.
Right,
And
right. And
see
according,
the-
you chose a Synergy because you like
he
features of the stent,
elderly,
they bought lunch today, what?
No, he's elderly and he's going to be on the Novak. Yeah.
NOAC. So this is the ideal setup.
I wanted
Yeah.
to bring up I wanted to bring up the financial component about this and the readjustment for mortality rates, mostly because our cath lab management. is
So
sitting
you
right
see
over
the
here.
technique I used to go into the side branch. So there was some resistance because of the calcium, despite us
is a
doing a high
3-5
pressure balloon as well as cutting balloon.
Stent.
So I pulled the stent back into the guide,
3-5-20.
got the guide in and went with a better force. Now we are going with a 3-5-20 into the from left main to ostial LAD.
You made that deliverability look so spectacularly easy with that synergy.
Yes. So, well, I mean, clearly,
I don't think
I
it's all synergies, some technique involved too.
Yeah. But key, the many times when you get stuck into this calcium spicule, don't push, pull
Good
back and go
answer.
with the speed.
Good answer.
Yeah. Yeah. So pull back and go with the speed. Yeah.
In people with these, with a low EF like this after rotational atherectomy, do you think they're more prone to leaving a support device in for a longer period of time subsequently? I mean, his blood
No,
pressure has looked
no, I would say no, but once you
So
have done your
what
good
are you
job,
going to do with support, guys? What are you going to do with support?
we'll take it out in the end. And then we'll
Are
take it out in
you
the end.
per-closed in pre-closed
Yeah.
fashion?
Yep,
Or
already has
how
been
you
done.
doing this?
Yep,
Yeah,
pre-close.
we pre-close.
So
So
I
now
would-
let me
I
go
would
through
just
the
make a
steps of
plug
the
for-
mini crush.
Yeah.
So the side
I'd
branch,
make a
I'm going to
plug
bring
for
the side branch.
hemodynamically guided complex PCI, that if you see changes in the output or the wedge pressure, they would signify you should not do the next vessel, or maybe if
Ready?
you've only done one
Yes.
vessel, you should leave the impella in until their hemodynamics normalize and then pull the
I
impella.
think I have to pull
We've
back the
gone
side branch
our
in a little bit
program
inside.
almost invariably
Where's the side branch?
to putting a 14 French cook in, especially if we think it's going to
No,
stay
I'm
in,
pulling it a
because
little
it
bit
gives
more.
you sort
Okay,
of a
now
mulligan.
better.
If it stops
Okay, the
functioning,
side
clocks
branch?
off, whatever, you can just pull it out through the 14 French cook and replace
Okay,
it. if you
go off
need
with the
That
side
was the
branch.
case, but that was what I was showing yesterday was there's a.
So we have the side branch, millimeter into the main vessel. We're going up with the side branch stand.
And that's where the thrombus.
14
Down.
atmosphere. And we'll pull back at the ostium.
Get a LVDP.
New fielder.
If the LVDP is elevated, then we keep them
No
on
need
for another day.
2-12
And there's, now
I mean,
they-
one
now-
quick
now they have the
question, just by-
recapturable sheath,
Good, yeah.
the sheath that you can get a wire through now, so you don't have to worry so much about leading long 14 French sheaths in.
Yes.
You guys are doing a
So now-
spectacular job. I mean, this is really an excellent demonstration.
Wait.
You're making a very complex case look
No, I have to
pretty
take the wire out. Side branch wire has to come out. We just want to make sure the side branch is okay. You want to give some dye? Just a little dye. Yeah, looking
good.
good.
So just
Side
for
branch
some
wire
housekeeping,
coming out.
We got about
Yeah.
12 minutes left.
Good. We'll be done by that. We'll do the IVUS also
I
in
know
bed
you will.
with that.
That's an eternity for Dr. Sharma.
Go 2 millimeter in.
Just out of curiosity, what was the LVDP before you put the?
Oh, actually,
impella
this
in?
patient has a normal right heart pressure and EDP was 12. Good.
Okay, so this is an interesting, seemingly paradox when you have a low EF but have a normal EDP.
Yeah.
Yeah, I
So
think
they're
it's
fairly
still-
well compensated.
New
I
2.5
think this
balloon,
still
right, to go
was
to the side branch.
an easy decision to go with mechanical
Compliant?
support. I know we look at hemodynamics.
Okay,
and
little picture.
sometimes with a 45% ejection fraction, that may be what makes the decision, but in this case, don't you agree?
No, I'm not saying that you wouldn't put it in, I'm just
Yeah.
saying that you
This
actually
one's
sometimes
synergy is
want to
not
give them
right.
fluid.
Right.
Yeah,
Because
exactly.
you'll
Take
get
them up.
suction and Lawrence
Right.
from the impella.
Yeah.
But the
Yeah.
harder decision is whether to take it out or not. That's the.
No, but I can tell you, Arthur, I would say, once you have done your good intervention, even you have a minor little, many times you may see a little bit of EKG changes because there was a lot of debris downstream. The good result,
Right.
I would definitely will take it out because in old patient, after your good intervention, your biggest outcome will be your vascular complication. So we know that more you leave, higher will be the trouble. So I can
So
tell
where
you,
are you guys at right now, Annapurna?
We are going to recross the side branch since the side branch wire, the tip was not good. We are going to use a new fielder wire. Otherwise, the side branch wire that was in the guide, I would usually use the same wire to recross the side branch. Now this is a new fielder that I'll be using to get into the side branch.
Okay, and you're going to kiss now shortly, is that
Yes.
it?
Yes,
Yeah.
yes.
so coming back to
And
the
tell
point,
us your,
yeah.
tell us your kissing technique. Is it just go in with two balloons? Is it a two-step sequential at each one at high pressure, and then
That's right.
intermediate pressure simultaneous? How you do this?
So basically, the key, we always say,
No, I
you
think
have
I'm
to
in a
go with a
small
smaller
branch.
balloon first. Huh?
Some lie.
Yeah, good. And don't use your first deflated balloon, very rarely will go. So this is the case, what have we have?
2512 compliant.
This is the compliant balloon now 2.512. Once you open the ostium, then you bring your two balloons, and I know the whole issue whether you do a sequential dilatation or kissing dilatation and the proximal segment with the pot, a lot of reiteration of the strategy, but key is that for the bifurcation with a mini crush, just like a DK crush, very meticulously going both at the high pressure with a non-compliant balloon.
Got it. Mike, what's your technique for the final kiss?
What do you want? 35,
Yeah,
20,
I do
35,
no.
20.
Both same
High
time?
pressure.
Bridge?
See?
Both
I told you.
same time.
Very difficult.
Yes. So now you see that
And why
even
would
at
they want
the
to-
new balloon, get a 1.512 also.
1.5.
Yeah.
Gonna
If it doesn't go.
anchor
John,
it
what do
with
you do?
I think we saw
Duo.
it again on our bifurcation that Jazz did.
We'll anchor it with this.
You know, you often save a lot of time just by going with a 1.5 or a smaller balloon.
Yeah. Okay,
Before
get a
going up with
1.5.
the two other
Yeah.
balloons.
1.5.
When I try to
Either
decide
we
what I'm gonna
recross-
do, I just say to myself, what would Jazz do?
How would Jazz?
Since I told you, do not use synergy. Never recross.
So now I know
Yeah,
what
you can
Jazz
get under
Yeah.
struts pretty easily if you don't.
Yes.
Okay,
we
2 or
did-
A
12?
couple of new balloons. The
212.
1.5 Takeru balloon is on a stiffer shaft and has a slightly lower profile. Is really good 1.5 crossing balloon, and then there's a 1.0 Sapphire balloon, super low.
Hold on,
profile.
which is 1.5.
The key is that both of those, all of the
Not 2.0?
1.5 balloons and smaller have a mid marker. It's the
2.0?
mid marker that's the fattest part of the balloon. And if you use a long 1.5 balloon, you can often get the nose of the balloon wedged into the bifurcation and do a sequential ballooning through the bifurcation.
Aaron, am I the only one that will go to a glider? It sounded like that today. Do you use a glider
I
when
don't
you
use- No.
don't know?
I can tell you,
I have like-
we used to,
I default to a glider, but I don't start with it.
Say it again, Samin?
yeah, we actually used to use glider, and believe me, we gave it a good try. We didn't find any advantage of that glider, being a 4 millimeter balloon and so, yeah, personally. We actually, now we have
Another
about
scenario. This
recross.
is another scenario, Samin, where you've
Recross.
got a stent in the LED, and it'd be very safe to put an anchor balloon in the LED.
Yeah, that's what we just
Take your
talked about.
30NC,
Yeah. Let's say recross
put
again
it
first.
in the LED and use that to anchor to push your balloon
Yeah.
through.
This is
And you don't lose
Let's
anything
anchor.
because you're going to
Yeah.
be using that same balloon to post dilate.
Yeah.
So
Yep.
put it down there ahead of time, anchor it.
Yes.
It's a great
Yep.
backup and support.
We actually just
number of
talked
other,
about it, that do we do anchor or recross?
But one thing you should notice, though, if you're going to use a glider, you can't do the anchor technique. The glider's a very high-profile balloon. You can't get both through unless you're using large.
Seven French.
Yeah, this is a 7 French guide.
No, but I'm talking, you can't get two of them through the guide, though.
The balloon.
good.
Yeah, that is true.
Wait,
That's
what
not
are you doing?
I believe, I
forget
agree
it.
with the pot.
Okay, good. Go up. So this is our
But I love it.
LED.
I love the anchor
Good,
technique.
good. Let's go.
This cannot go now. You inflated it.
So that's okay. We'll go. Go. Now it's a 1.5 balloon. If not, then you have to rewire.
What balloon is that?
Wire
It's
is
got
it?
two markers on it.
Yeah, 1.5.
It's a
What balloon
1.5.
is that?
The two.
Huh?
Which
It was 2.0?
brand?
It's a 1.5 with two markers?
Yeah, that's a two.
think they
it's got
gave you
two
2.0s
markers
to
on
me.
it, so I mean, you need a one,
Yeah.
1.5, and if you can
1.5s
get
or one marker.
Takeru, go for it.
Or even a 1.0 balloon.
We may have to recross.
Yeah.
Apex-
Or
Apex
recross.
push or Takeru.
Yeah.
No, the wire.
So the point
See
that was made up here is that, it's
Do
not
a pot?
It's not smaller than 2.0
Four.
because there's two markers.
Get a 1.0 balloon.
Automatically, it's at least a 2.0.
One no
One,
balloon.
no.
one, two
Let's get
balloons
one.
have
This
a
is
single-
That's to
1.5.
keep the
Yeah,
profile.
this is the 1.5.
smaller.
Yeah.
Let's go quick. Okay. What do you want to do? Recrossed? Good. Let's go with the
And
1.5.
there's no difference in the crossing profile of a 2.0, 2.5, and 3.0 balloon.
Exactly.
They're all
This
the
is
same.
1.5?
1.5, yeah.
Again,
Good.
the 1.5 has
Okay, and get a 4.0,
profile, and
8 or
it's that whole
12
marker issue.
high pressure?
You have a
408.
balloon in front of the marker.
Yes.
So Aaron, of all the ones you mentioned, which one do you think is the most reliable getting across? The 1.0 or the?
In my vast experience, look,
Advance this part.
I've had a lot of success with this Takeru balloon from Chirumo. It's
From-
across a lot of things that I've struggled
Yes.
with otherwise.
Yes.
So
No, no.
I don't have a trial for you. I have some anecdotal baloney experience. and
Okay,
that's
let's
all.
spot
It's not
now.
baloney, though. I mean,
Okay. Pot.
I don't have trial experience on
Four,
jumping out
right?
of an airplane
Yeah,
with and without
yeah.
a parachute, but I think I
Dilated
know how that
Austin,
ends.
Okay.
I've been wrong
Yeah,
before
yeah.
when I
Depends on the altitude.
take my N of 6 studies.
Yes.
So Jazz is saying that he
no, we are
recommends
good.
pot technique.
Yes.
No, we
that-
just did pot with 3-5, but we
but
can
we're
take
doing
a 4. Yeah.
approximately. Yeah. We're going to a 4 now.
I think meanwhile, if we recross.
So this is going to be a good test, right? We've got to
Yes.
do it at the patient becomes their own control.
Yeah.
To find out how effective
This one
pot
has
is.
to come out.
Huh?
For pot, this has to come
We're
out.
always about research.
Yeah, whatever we do, we only change one variable at a time,
One variable.
Good.
Okay, That's the purist.
so we can learn.
I think we have to recross.
Okay.
Huh?
I will
Yeah,
recross.
let's recross.
The curse of the crush technique.
Okay, so you want to explain why you're recrossing? This is interesting.
This 4.
No, I
No,
think-
just a different strut to see if that strut we may be able to get the balloon through the different strut. Okay.
And do you aim for a distal sort of strut
Right.
at that carina?
that is correct. So
As much as
compared to the DK crush, they're trying to tell us that go to the proximal one. For the mini crush, you want to go to the distal. New wire?
Yeah.
You
So
feel
let's get
sometimes you
everything
want to
new.
leave the one wire down and go for a
Yeah.
second one and put that in. That serves as a marker for you, a placeholder.
Take both of them out. Good. We'll get a new one. Do the pot. Let's do the
This
pot.
is 4-0.
Yeah.
Fielder, I think they said, why don't, maybe a Xi'an blue or something that's with less body, may bias less.
No, I think it just have to be
Okay,
pot
so
and
take us
recross. Yeah.
through,
Yeah.
right, take us through your algorithm. This
Yeah.
doesn't work. What's your next 2 steps? We got
Yeah.
Aaron Grantham here saying don't perseverate on a catheter. He's a CTO guy. So what are your next 2 steps?
Yeah. So one is the
We'll recross it. Now we did the pot.
Pot.
This is a 4-0. We have up to 20 atmospheres. This is a real pot. Okay, down. And now we'll recross. We'll try to get through a different strut, whether it is proximal, distal, and one of the balloon will definitely cross.
Now what wire are you
get
going to
one
go to
balloon
next?
also.
one
It's a
over.
fielder, same.
The fielder or whisper. I think you need a hydrophilic wires.
Not to pressure you guys, you're at 2:45, 2 minutes and 45 seconds left. You guys are doing a great job. This is really very instructional.
There was an interesting paper in JACC CI, it's probably 3 years old now, but they did analyses of side branch wire damage and side branch wire crossability, and they found the jacketed wires to be better. When they took them out, they did micro CTs, blew them up several thousandfold. The unraveling of the coils was much less in a jacketed wire.
So what are
Like
your
fielder.
choices on jacketed wires?
So there's Fielder, which is a
Yep.
little bit stiffer tip than Fielder FC. So
FC.
Fielder FC is my preferred.
Yeah.
And then Xi'an Black, which
Yeah.
is a Fielder FC with the Act 1
Some
double
die.
core design, has the best torque transmission on the
good, good.
market.
So Fielder XT, Fielder FC,
Let's go
and
through.
black.
Some people use
got 2
Whisper.
minutes only.
Whisper's got it doesn't have
Now
a
you know
stainless steel
why I
core to
said
the
don't
tip.
use
It's not
this.
as torqueable.
Stand,
And it's a little bit harder to see
synergy.
than
I
the
mean, how many
Asahi
times you have
family of
done
wires.
Romas?
Okay. So now
Bottom
let's do
line
the
of this
test quickly.
case is that
Yeah. Go. So
Bottom
you
line
said
of this
that.
case is
Yes.
that you guys are going to make sure that
3-5 balloon we have.
you complete the case. You're going to do
Bring
your
it.
kiss.
That's it.
Yes.
So and we all learned that once you don't do the kiss, it comes and haunt you. So kissing is always good.
We've always agreed with that.
Yeah.
There you go.
Good. So this
Okay,
is
deep
a
breath.
yeah. I'm going up now.
Go, go.
Okay.
good.
So this is a 1/0 a sapphire. 1/0 5 millimeter sapphire.
They named two
Yeah.
variables, darn it.
Yeah.
2 variables you did. We can't
know.
do that.
3.
I
New wire, new cross.
and pot.
So no resistance going across with the 1/0, Sabine?
Nope.
No, it didn't cross.
Just
I don't
it's
think
still
it
there.
crossed.
Yeah, good. It'll be okay now.
They're not across.
Not
They're
across.
Give me a
Get a
1.25.
1.5
1.25.
1.5.
Knocking on the
No, no.
door.
Yeah,
We have
exactly.
1.5.
Knocking on the door.
So I think, again, a great example, too, of how you have to have a whole series of step A, step B, step C, as to what you're going to line up. I mean, way back in the
1-5.
day in high school, I used to be a wrestler, and your move had to be followed by a counter move, followed by a counter move, followed by a counter move. You had to have 4 things lined up every time you were going to throw a
I
move
think
on
that's
somebody.
that's the important point of this stage of the procedure is having your next 2 or 3 moves at least figured out in your head,
And get a,
so that
Corsair.
so that the lab and the person next to you know where we're going.
Yeah.
Just
Absolutely.
those alternatives.
Very important. So coming back to the points that what else can you do? So what I do many times, if nothing worked here, try the Corsair. Just open the ostium with the Corsair, and then you will be able to get your device in.
You want to try the balloon in the
Jazz, what
LED
do you
now?
wanna
Make
do
Corsair.
here? We're running out of
3-5.
Corsair, yeah. Corsair.
Deep breath?
No.
No,
Good. Yeah,
I don't think we should do the Corsair.
You want to go on to a lecture, or what do you want to do? You want to stay with
I'd
these
go,
guys?
I'd use the anchor
3-5.
technique again and try it.
yeah,
with a
Yeah.
we'll try.
Yeah.
No, we
Corsair,
want to try.
Corsair, Corsair.
From Corsair, this is 3-5.
Second
Yeah.
case.
So, good. So I know we are going to go to the peripheral case very soon. Let me just take last picture, one technique of the Corsair, and then if that's a, like you are always thinking ahead, what else need to be done? So
Okay,
this is
so
Corsair
30
will go.
seconds more,
Yeah,
okay?
that's it.
30 seconds more, Samin.
Yeah, so
Yes.
you're seeing all the techniques here for side branch entry.
And that's the important part.
Double
John.
wires, pots, smaller downsizing balloons, specialty balloons,
Ooh, wire,
skiving
wire.
of
It's okay, don't worry.
of a
It's
glider,
not going.
a anchor technique, using a microcatheter for CTO work, but actually to get into the side
Keep
branch. And you could even bring a Guidezilla in up there and back
Yes.
up your microcatheter. So that would be another move.
And I'm going to have the final word here. I think that's the important
Keep
thing.
going.
You're seeing all the
wires.
techniques. They're eventually going to
little
get
more.
where they want to go, no question. It's probably going to be off camera.
little more. Good.
But you
Go.
saw them,
Go.
next step, next
Yeah.
step, next step.
And we are going to show you that
always
picture.
moving.
Yeah,
Samin
we are going to take a last
and
picture
Aporta,
here.
Thank you. Okay,
Yeah, yeah.
go for it.
I'd just say one other thing is that
Yeah.
it's really important to know how your wires are constructed and how that translates into performance, which balloons you have available and how they work and why they work, which other technologies like atherectomy, that if you don't know what you're pulling off the shelf, how it was built and how it's designed to perform, and you're just going to be guessing.
Yeah, it's hit and hope. All right, you guys, thank you very much. You two are terrific. Glad I got to play your Dr. Phil today. Really good.
Good job, guys.
I think it's also a great example too, as Aaron's alluding to, is that all CTO techniques and stuff are applied for other strategies.
Yep.